Morning, everyone. Yeah, today's topic is hypoxemia, and I really believe that each and everyone who is going to take his time and listening, following this presentation, is going to have sufficient package about hypoxemia. Let us go on with the defining hypoxemia. Hypoxemia defined as the partial pressure of oxygen PaO2 in the blood of less than 6. The main symptoms, but not limited for this, there is a shortness of breath, confusion, a rapid heart rate, and a bluish tint to skin or cyanosis. So you can ask why it is important to learn hypoxemia for healthcare providers. Once the hypoxemia is not treated early, it will cause many complications that can vary from impaired organ function, where the body tissues and the organs rely on the constant supply of the oxygen, and without it to the cells began to malfunction and can die, leading to permanent damage, especially in the critical organs like the brain and the heart. Once the treatment is neglected, it will also lead to serious complications like organ failure, respiratory or cardiac arrest, all death, as I have said. The main causes of hypoxemia are usually grouped into 5 elements. First one is hypoventilation. Second one is low FiO2 or fraction of inspired oxygen, diffusion defect, and the VQ mismatch, which is ventilation perfusion mismatch, and shunt. Let us go on, starting with hypoventilation. In simple words, when we say hypoventilation, it is when there is insufficient ventilation, meaning that the amount of air entering the lungs is too low, resulting in inadequate oxygenation of the blood. How does this come? It starts with the reduced ventilation or air exchange in the lungs, which leads to insufficient oxygen exchange in the alveoli, causing the decrease in the blood oxygen levels and often increase in carbon dioxide, which is hypercapnia. The examples, as you see, there is CNS depression, where like drugs that depress central nervous system can reduce the respiratory drive, causing hypoventilation. Among the example of drugs that can depress respiratory centers in the brain, we have opioid overdose, like opioids like heroin, morphine. All those can decrease respiratory drive, leading to shallow or slow breathing. Other class is sedative use. For example, benzodiazepines, barbiturates, or alcohol can also depress respiratory center in the brain. Other example, we have neuromuscular disorders like ALS, amyotrophic lateral sclerosis, where there is a progressive neurodegenerative disease that affects motor neurons and leads to respiratory muscle weakness. Other example for neuromuscular disorders, the Guillain-Barré syndrome, where there is autoimmune disorder that affects peripheral nerves, including those controlling the breathing muscles. On the obesity hypoventilation syndrome, of course, it is caused by excess body weight, where this overweight can reduce the lung expansion and ventilation, leading to the hypoxemia, especially during sleep. The effects on the oxygen, it's low oxygen intake and the CO2 increase in the blood. The second cause is low fraction of inspired oxygen. Low fraction of inspired oxygen is defined as the low oxygen concentration in the inhaled air. Low FiO2 can also be defined as the situation where the amount of oxygen in the air being breathed in is lower than normal, which limits oxygen uptake into the lungs and subsequently in the blood. How does this come? There is reduced oxygen content in the air means that the partial pressure of oxygen is too low for sufficient diffusion in the bloodstream. This will can be caused by higher altitudes or hypoxic gas mixtures. For example, on the high altitude, as the altitude increases, the atmospheric pressure decreases, which in turn lowers the partial pressure of oxygen, to mean that at the higher altitudes like Himalaya, Everest, the partial pressure of oxygen in the air is very low. This can also lead to hypoxemia. The second example, which is the hypoxic gas mixtures, you know that in the environments where oxygen levels are intentionally reduced or replaced with other gases, for example, in certain industrial settings or confined spaces, the oxygen available for the breathing can be inadequate. Yes. The effect on oxygen, where there is less oxygen, the person will have less oxygen for gas exchange. The third cause is diffusion defeat. Diffusion defeat is the impaired movement of oxygen across the alveolar membrane. It can also be defined as the impairment in the process by which the oxygen diffuses from the alveoli to the blood into the bloodstream. The mechanism for this to occur, the gas exchange between alveoli and the capillaries, is impaired due to the changes in the structure of alveolar capilla membrane or reduction in the surface area available for diffusion. Most causes for this defeat, we have first one is pulmonary fibrosis. Of course, when there is scarring and thickening of the alveolar walls, that impair the diffusion of oxygen from alveoli into the blood. Second point is acute respiratory distress syndrome, ARDS, where this condition can lead to the inflammation and the fluid accumulation in the alveoli, causing the thickening of the alveolar capillary membrane, of course, preventing the effective gas exchange. Third one on the list is the emphysema. The emphysema, you know that there is destruction of alveolar walls, which can lead to the decrease in the surface area for gas exchange, thereby impairing the ability of the membrane to oxygenate the blood. Yeah, of course, the oxygen cannot diffuse properly from the alveoli into the bloodstream. Fourth one is ventilation perfusion mismatch, meaning that there is inefficiency, lung ventilation in the blood flow balance. What does it mean? It means that there is the imbalance between ventilation or the air that reach the alveoli and the perfusion or the amount of blood in the capillaries surrounding the alveoli. For this to happen, there is the ideal oxygenation, which happens when the ventilation or air flow matches the perfusion or the blood flow in the lungs. The mismatch comes when the ventilation and the perfusion are not properly coupled or balanced, which leads to the reduced gas exchange and then hypoxemia. Yeah, the examples, we have pulmonary embolism, we have a COPD, we have asthma. How does pulmonary embolism cause Vicky mismatch? There is a clot that is obstructing the blood flow in the lungs, usually in the pulmonary artery, and then this will cause the poor perfusion in the ventilated areas of the lungs, and then creating Vicky mismatch. On the COPD, you know that in the COPD there is a narrowing and the damage of the airways. And this will lead to the areas where the ventilation is inadequate, but the perfusion remains normal. And this, there is in the imbalance of the two, between ventilation and perfusion. On the point of asthma, you know that in the asthma there is airway constriction. And this will reduce the airflow to certain parts of the lungs, thereby creating the areas with low ventilation despite the normal perfusion. And this imbalance will also lead to Vicky mismatch. Yes, I think we are together now. The last cause of hypoxemia is shunt. Shunt, it's like blood is bypassing the lungs or does not undergo oxygenation before being distributed to different parts of the body, cells, and tissues. It can also be defined as the blood that is bypassing the alveoli, either due to anatomical abnormalities or physiological conditions, and this will prevent oxygenation of the blood. For this to happen, as you know, or the blood flows through areas of the lungs that do not participate in the gas exchange, either due to congenital heart defects or diseases like pneumonia and RDS. All those can lead to hypoxemia because this blood is not oxygenated. The examples, you have anatomical shunts, where, for example, in the congenital heart defects such as atrial septal defect or ventricular septal defect, the oxygenated blood bypasses the lungs and the intersystemic circulation, leading to hypoxemia. On the physiological shunt, in the severe, for example, in the severe situation of pneumonia, there is a consolidation in the alveoli where the blood flow is directed through non-ventilated or fluid-filled areas, and this will result in shunting of the blood. The blood will pass this area without being oxygenated. The case of ARDS, in ARDS there is a severe inflammation that is causing alveolar collapse and the fluid accumulation. This will lead to areas of lung with poor ventilation but intact blood flow, creating physiological shunt. About the diagnostic test, we have pulse oximetry or SpO2. Of course, it's a non-invasive and quick test that estimates oxygen saturation in the blood. The normal value is from 95 to 100%. We say that a certain patient is hypoxemic when his or her SpO2 is less than 90%, to suggest that, of course, it is hypoxemia. On the arterial blood ABG analysis, you know that it provides the more accurate measurement of oxygen levels, PaO2, and the carbon dioxide levels, which is the PaCO2. When the PaO2 is less than 90 millimeter of mercury, we say that this is typically diagnostic of hypoxemia. When PaCO2, it may be normal. Having the lower PaO2 but with normal or abnormal PaCO2. When it is low, it is hyperventilation. When it is high, it is hypoventilation. ABG parameters like PaO2, the normal value is 75 to 100 millimeter of mercury, and the low levels below these are indicative of hypoxemia. About the pH, can show acidosis or corrosis, which may help identify the underlying cause, like respiratory acidosis in hyperventilation. Yeah, things like that. Yeah, differential cause differentials. On the cause differentials, you know that for you to differentiate the cause of hypoxemia, you have to narrow down the cause, where you can use the specific diagnostic test to differentiate between these major causes. For example, in ABG analysis, you know that it helps to determine whether the hypoxemia is caused by hypoventilation when the PaCO2 is high. Then the diffusion defeat, you will have a normal PaCO2 Vicky mismatch. You will have normal or elevated PaCO2. About the shunt, low PaCO2 and low oxygen saturation despite high FO2. It will not increase despite increasing the oxygen supplement. For the shunt, it will not increase. Yeah, and you have to know to challenge the oxygen. You will give the oxygen to the patient when the real cause of hypoxemia is unclear. When you give or you administer 100% oxygen and the partial pressure of oxygen in the blood improves significantly, this will show you that the cause maybe is Vicky mismatch or hypoventilation. But if you administer 100% oxygen and the partial pressure of oxygen does not improve, the cause may be shunt or severe diffusion defeat. About the management, there is oxygen therapy where you will use oxygen cannula depending on the level of hypoxemia, oxygen mask, and an breather mask, all those to increase the oxygen levels. But you have to know that in the severe cases, you can need ventilatory support. The treating or the treatment of underlying causes. For the hypoventilation, address with medications like naloxone for opioid overdose and ventilatory support. For low FiO2, for example, in high altitude, you have to provide supplemental oxygen. For the diffusion defeat, like pulmonary fibrosis or ARDS, you can use corticosteroids or pulmonary rehabilitation and ventilatory support in severe cases. For the ventilation and perfusion mismatch, like in pulmonary embolism, asthma, COPD, you treat with bronchodilators or anticoagulants and mechanical ventilation, of course. For the shunt, like ARDS, congenital heart defeat, you treat the infection when it's the cause, or you correct the congenital defects and use a mechanical ventilation. Thank you very much, friends, for taking your time watching this video. I think you have unleashed